And welcome to another episode of Postpartum Connections. I'm your girl Tashia. I have my friend Ashley Davies with me, and we are welcoming another great friend, Dr. Katina Brown-Burgess. And on this episode, we are going to be talking about the first few weeks advocating for your health, your postpartum journey. So we are joined here with Dr. Katina Brown-Burgess, who is a native Floridian, born in Fort Lauderdale, Florida. And she's been practicing obstetrics and gynecology now since 2006. She's a Boyd Anderson High School alum. She got her bachelor's in biology from Emory University. And then she went on to medical school at Nova Southeastern College of Osteopathic Medicine. During her medical school journey, she knew serving others was going to be the compass that would navigate her medical career. She became a National Health Service Corps Scholar, and then went on to graduating from residency from Detroit, Michigan, where after that, she became the department chair in Milwaukee, Wisconsin at a federally qualified healthcare center. After that, fulfilling her federal government commitment, she went on to be an assistant professor at her alma mater, right?
That's correct.
Awesome. That was beautiful. So currently, Dr. Brown-Burgess serves as the chair of the OBGYN department at Broward Health Medical Center and the medical director of the Broward Health Point perinatal clinics, okay, which is amazing. They are moving forward in implementing initiatives such as enforcing policies to improve patient care. Her department has implemented a lot of the Florida state initiatives, including the protocol on OB hemorrhage, implementing an initiative to decrease the number of cesarean deliveries for first-time mothers, and most recently, the initiative to promptly managing hypertensive disorders in obstetrical patients. That is powerful.
Yes.
You're doing great work out here, and we are excited to have you.
Thank you.
Thank you so much for being here.
Thank you. Thank you.
So I'm going to kickstart us off.
Please.
I know we're advocating for our health after having a baby. I wanted to know, what is the difference in terms of signs and symptoms versus C-sections versus vaginal deliveries that the family should be looking out for?
So when we talk about postpartum recovery, whether it's a C-section or vaginal delivery, the patient needs to monitor for signs of bleeding. Okay, you want to make sure that she's not having any delayed postpartum hemorrhage, which can occur. And so it's very important to monitor for signs of bleeding, monitor signs for infection. If it's a C-section, you want to look for your incision. Is there any redness? Is there any swelling? Is there any drainage or a malodorous smell coming from the incision? Also, if she had a vaginal delivery and had an episiotomy, she wants to check and make sure that there's no swelling or no drainage from the incision itself. And if she's experiencing more pain than she usually should be experiencing. So each day that she's out from surgery, a patient's out from surgery, the pain should be less and less. If after like 3 or 4 days, all of a sudden the pain is increasing, then there could be something wrong. It's important that she contacts the office. She may talk to a nurse, or she may actually get into an appointment and to see her physician to make sure that she is, make sure that there's nothing going on. So bleeding, infection, you also want to look for signs of shortness of breath, right? If she's preeclamptic, if she's in fluid overload, what if it's a pulmonary embolism? Okay, so those are some of the things that you want to look for immediately in that postpartum period. So that first 7 days is very important.
Wow.
Granted, it's commonly known that you have 6 weeks maternity leave for vaginal delivery, 8 weeks maternity leave for C-section. But in reality, a woman fully recovers from delivery, it can take up to 3 months. And for some women, it can take up to 6 months, depending on if she's had some OB complications or pre-existing medical conditions, or say for instance, she had a very traumatic delivery that may require her to see a mental health provider. She may have issues with depression or anxiety. So that takes a little bit longer to recover in the postpartum periods, even if she's got complications with her breastfeeding, where she needs additional help. That's important. So I always tell my patients when they ask me how much time they need off, I say, well, we can put down the basics, 6 to 8 weeks, but you can be off for a whole 6 months to a year.
It's not like Canada where you get like a year
off. Oh, you're off, right.
I mean, technically you could take a year off, but it all depends on FEMLA, it depends on your job. I mean, I'm just going to say a side note. My father, before I had children, my father said, your first kid, you really should take a year off. I didn't take a year off. I only took off 3 to 4 months. But even then, it's the recovery process, because recovery is it's beyond the delivery, right? Yeah. It's actually the mental health, it's actually being supportive in the new role that you have now, whether it's your first kid or your second or third kid.
Absolutely.
And so that is key when it comes to recovery process.
Right.
So I think that people try to make recovery a finite process for childbirth, and it's not.
It's not.
Instead, if there's like breastfeeding issues that could
right.
add on to the mental health.
Absolutely.
Yes. So that's key.
There's so many variables during this process. So it's just not just popping out a baby and then you just keep it moving. There's just so many things to being able to consider. Just even as yourself, as you talked about how you didn't get a chance to take off the year, being working moms, like we don't necessarily have that luxury to being able to do so. When you were talking about those signs and symptoms, you had mentioned about preeclampsia. Can you share any stats on the postpartum preeclampsia and how often that women are being diagnosed now?
Well, it's very interesting because preeclampsia is a spectrum. I consider a disease process that it's a spectrum, meaning superimposed preeclampsia, severe preeclampsia, HELLP syndrome, eclampsia, right? And so when we talk about stats, we know that women are not consistently being tracked for the diagnosis of preeclampsia. Some people call it gestational hypertension, and sometimes when patients go home and come back, are they given the diagnosis and is it coded properly? So one thing that the CDC a couple years ago discussed, how with the maternal mortality rate, it wasn't really the exact accurate rate, right? Because of how we were collecting data and how it was reported. And that's the same thing with preeclampsia. But I will tell you, I did get some stats. I'm a statistic person, but I do know the downside to statistics. But 1 in 12 women will be diagnosed with preeclampsia in the United States. I will tell you about 75% of postpartum preeclamptic related deaths occur after birth, right?
Is that because they were fine during labor and in the hospital, no signs of symptoms of preeclampsia, and then went home and then all of a sudden had signs and symptoms of preeclampsia, or that it wasn't necessarily addressed right away?
It's a combination of both. So one, if they were not diagnosed with preeclampsia during the labor process or even antepartum or before delivering, they're probably not given those symptoms or signs to look for when they were discharged home, because the assumption is that, they're fine, they're not at risk for preeclampsia. And so patients are not given that information. And then sometimes when they do realize that there's a problem, it might be too late by the time they show up to the ER. And that's 75% of those deaths occur after.
And what are they dying of exactly? Is it a seizure? Is it embolism? When you say they're dying from the preeclampsia or the eclampsia, or stroke?
It could be stroke, it could be cardiomyopathy. Okay, postpartum cardiomyopathy can happen where it's not affiliated or associated with any other cardiovascular disease. Also pulmonary edema. Right, so those are so that's why shortness of breath is one of the symptoms of pulmonary edema. And so those are some of the symptoms that you want to look for. And so if patients are not educated about the signs and symptoms, then when they go home, they're thinking, oh, it's probably just because I just gave birth. But I will tell you that most symptoms and most diagnoses of postpartum preeclampsia occur within the first 7 days after delivery. So the first 7 days, you have to really be attentive to what's going on. And it's difficult. A new baby comes home, you're sleep deprived, you're trying to get the breastfeeding schedule together, you're trying to get the sleep schedule together. You might have family members around. And so that's where you need a supportive environment, because mothers are so into taking care of the newborn that they're neglecting the signs that they may have.
Wow.
So I will also tell you this. In the last 2 decades, the incidence of preeclampsia in this country has increased.
I see a lot of young patients in the hospital.
Yes.
Young.
Yes.
And I'm like, what's going on? Like, is it our food? Like, what is going on?
Right.
What's
Right. To your point, right? Is it preventable? Like how can a mom, doesn't matter her age, say, okay, I want to prevent this from happening, so I'm going to do A, B, C, and D.
All right, so let me lean in a little bit. Hold on, let me lean in. As leaders will say, let me lean in. Okay, so preeclampsia is not like chronic hypertension. Okay, it's not like chronic hypertension. So totally get that out of your mind, like high blood pressure.
Right.
To date, we do not know the true cause of preeclampsia, why it happens. We know the risk factors, we know the signs and symptoms. So we're kind of like working this backwards. Okay. So preeclampsia, it has a lot to do with an inflammatory process in the body. Inflammation, the human body does not like inflammation. As we get older, we do have like a mild form of inflammation because our arteries get hardened, and that gives us that's a form of inflammation. But the foods that we eat, pre-existing medical conditions like obesity, hypertension, diabetes, autoimmune diseases, anything along the spectrum of lupus, those can trigger inflammatory processes in our bodies. When I teach my medical students, I tell them that preeclampsia is an inflammatory process. The theory is, this is a theory, that the mother releases pro-inflammatory proteins. Okay? Inflammation is not good because it destroys or it causes an endothelial cell dysfunction. Endothelial cells make up the blood vessels of part of our blood vessels. Okay? So it causes some disruption or destruction. And what happens is a whole release of cytokines and chemokines actually will begin to destroy those the areas of the blood vessels, meaning the cellular junction. I'm not going to get too scientific.
Yeah,
bring it back.
For our viewers.
Yes.
What does that mean exactly?
So what does that mean? You have swelling, you have edema. So when we talk about preeclampsia and the signs and symptoms, facial swelling. Okay, so one of the signs of preeclampsia is facial swelling. In particular, preorbital swelling is what you want to look for. Okay, not necessarily feet or leg swelling, because it could just be dependent edema related just to pregnancy.
Right.
Preeclampsia, right upper quadrant abdominal pain, because guess what? That edema is affecting the liver. Okay, so when you press down that area, ouch. But how
do you know when you're pregnant and everything hurts?
Well, let me tell you, there's a difference. When you get examined, when the person examines you, you will experience right upper quadrant abdominal pain.
Got it.
But also nausea.
Okay.
Nausea, and all of a sudden, out of the blue, if you start feeling nauseous in your 3rd trimester of pregnancy, and we're not talking about morning sickness. We're talking about you're done with the morning sickness, you're 32 weeks pregnant or you're 26 weeks pregnant, and all of a sudden you have this issue with nausea, you're throwing up, or you have heartburn, and people may say, oh, well, maybe it's your gallbladder.
Right.
That's a sign right there. Start the workup for preeclampsia. Yes.
Do you mind sharing what that workup is?
That workup is blood work. Okay, so you're going to check your CBC, your LDH, your liver enzymes, because you're looking for hemolysis, you're looking for elevated liver function tests, you're looking for low platelets, because that can cause you to eventually go into DIC. Then you want to check your urine, you want to check for protein in your urine. Okay? If you have chronic hypertension, if you've had it for a long time, and it has not been under control, you can be already spilling protein in your urine already. So you already have a predisposing factor if you have chronic hypertension. And so those are things that you want to look for when your doctor is working you up. Those are things that they're looking for to make sure and rule out preeclampsia or not, or gestational hypertension.
So just being able, when we're talking about advocating for ourselves, how important is it to have that relationship with your midwife or your doctor, to being able to even come to say, hey, I'm having these issues, or I'm not feeling right, in order to be validated during this time?
It is paramount. It is paramount for you to have a relationship with your provider. If you cannot seem to develop a relationship with your provider, then maybe that's not the right provider for you. Just because there are things that you're going to talk about with your provider that you may not want your family to know right away. Or you might just have feelings that you're not quite sure how to articulate, but you may have symptoms and you're like, Doc, I'm not quite sure what's going on, but this is the way I feel. And you should be able to have an open conversation with your provider. If you cannot, then it's not the right provider, because health is so intimate. I tell my patients, I'm like, look, are you doing okay? You can tell me almost anything. But it's important because it may be associated with something. So it's very important. Like, that relationship is so paramount.
Right.
Because when you begin to develop a rapport with your provider, from a provider perspective, I'm going to try to develop a rapport, because I know when things are off and when they're not. I know when something's just not right. And I'm even talking about emotional or mental health, or even health-wise. I say, you look a little swollen in the face today. Let's check your blood pressure. Your blood pressure's up a little bit. It may not be in the hypertensive area, but it's higher than what you normally are. Then I may say, you know what, we're going to check you for preeclampsia. So,
do they check every patient for preeclampsia?
Yes. So what they do is this: every patient that comes in, you're supposed to give urine. You've had kids, I've had kids. Ashley is with child. So every time you come into the doctor's office, I know we all dreaded this. We had to give urine specimen. Every time. And what we're doing is we're screening for glucose in the urine and protein in the urine. So if we know all of a sudden you're having protein in the urine, we're going to put the picture together. What's her blood pressure? Let's see how she's doing. Does she have a headache, which is another sign and symptom of preeclampsia?
Right.
And so all that matters. There's a method to the madness, as they would say. And of course, we don't a lot of times tell our patients, which we should, so that they are aware of what's going on.
Which is why your prenatal appointments are so important. So you feel like you don't think that you need to be going to these appointments, but it's important that you're going there, because this testing is preventive. It's prevention and being able to keep you on the right track. Do you find it hard to build rapport nowadays as a provider with the rolling door of seeing patients constantly? Is that a thing, or?
You know what? No, I don't.
Okay.
But it's a personality thing.
Okay.
All right, so it's kind of like speed dating.
Okay.
I would say it like that.
Okay.
But you kind of get to the point, and see, that's the art of medicine.
Okay.
As a physician or even a provider, you have a certain amount of time to get to know your patient.
Okay.
So it's skills. So those medical students that are in school for 4 years, part of that is the history taking. How to get your patient's story in a short period of time and still establish a rapport. Start in that conversation. That's a real conversation that, as healthcare providers, that we have with trainees or resident physicians and our medical students. How are you doing today, Miss Jackson? I see last time you took your son to a baseball game. Did you guys win? Start establishing some type of rapport and being there for your patient. Show up for your patient. And I don't mean not necessarily physically being there, but attentive, listening.
Right.
One of the things that and this is just off the grid, sorry, we're off the grid, but one of the things that I want to teach my medical students is the art of sitting down and listening.
Right.
We're so busy on the computer, and I know you guys see it. You're in a doctor's appointment. We're like on the computer.
Yeah.
Sometimes the doctor doesn't even sit down.
Yeah, sometimes they don't. And sometimes they just stand up and be like, okay, you're doing good, baby's
You
great.
feel like, as a patient, you feel rushed.
Yes, yes. And so it's an art and it's a skill to get the attention of the patient and to show the patient that you are attentive. That's a skill. That is a skill that it's a learned skill that as providers we need to do more of. And yes, we're busy on the computer typing away, but we need to stop, touch the patient, say, how are you doing today, actually?
I'm about to switch OBs and go to you.
I do that. I mean, I do that because I'm like, you feeling the baby? When are you guys having the baby shower? Just little things like that. When we're listening to the heartbeat, have a conversation. So establishing that rapport is so important.
Yeah. So I have another question, just to piggyback off of like the postpartum, like the preeclampsia. I've heard of so I've seen patients, they come back, they either get readmitted or they get put on magnesium, right? To help with neuroprotection.
Mm-hmm.
Should magnesium be something that we do during pregnancy or even postpartum as far as a supplementation? Is that helpful during this time?
All right, so let me tell you, everyone, regardless of race, age, everyone is prone to preeclampsia, okay? I don't care where you come from, your color of your skin, everyone is at risk for preeclampsia.
Right.
Some of us have a greater risk because we have other medical conditions that predispose us to a higher risk.
Right.
There's 2 studies that have come out in this country that I know of. One is a meta-analysis, which is not a good study if it's a meta-analysis.
Okay.
So magnesium supplementation is good postpartum. It helps with mood. It helps with muscle relaxation. It helps with sleep, okay, which mothers need. It does lower blood pressure, but that's only if you have chronic hypertension. If you don't, and if it's truly preeclampsia, it's not going to do as much.
It's not going to help with that
No.
with that specific
No.
condition. Okay.
So I'm going to break it down. I'm going to break it down because there's 4 different types of magnesiums that you want to think about, okay? You have glucinate, okay? That's good for sleep, relaxation, magnesium glucinate. Glycinate, excuse me, glycinate.
Magnesium glycinate.
It helps with relaxation, it helps with sleeping, which I think is a good thing for postpartum mothers because our sleep schedule is a little off,
Yes,
okay?
absolutely.
And it supports mood stability, and that's glycinate, okay? Citrate is the most common one, that's magnesium citrate
Okay.
for digestive support, for constipation, it's supposed to help with that. Then we have malate, which is more for muscle soreness and fatigue, okay?
Magnesium malate.
Yes.
Okay.
And magnesium gluconate
Magnesium.
is overall magnesium supplementation, okay? So there's 4 different types of magnesiums. You gotta make sure you pick the right one.
Okay. Okay.
Too much magnesium, studies have shown that it may affect breastfeeding or milk supply, but it's not 100. There's some very inconsistent studies. But keep that in mind. Usually I say 200 milligrams at night will help with relaxation. But you gotta know which magnesium that you're taking.
Right.
That's the most important. Now, speaking about magnesium, so IV magnesium sulfate, yes, another magnesium.
Right.
So that's 5 different ones I talked
Yeah.
about. Magnesium sulfate is a little different because we give that IV.
Right.
Magnesium sulfate is to prevent seizures during preeclampsia because we don't want the patient to develop seizures.
Correct.
And that's called eclampsia. When you have elevated blood pressure, you're spilling protein and you develop a seizure. It's called eclampsia. So magnesium, what it does is it's a competitive inhibitor of calcium. So calcium actually helps with communication between the different the neurons. Okay, with the neurotransmitters, those are like little chemicals in between our brain that communicates different things, neurons. So the magnesium displaces the calcium and it slows down the action potential or the signaling between the neurons. That is why if you've ever been on magnesium sulfate while in labor because you were preeclamptic, you felt like really lethargic and very tired, that's the reason why.
I remember some patients saying they felt like a burning.
Yes.
Yeah.
They get really hot, flushed.
Yeah.
Yes, because what happens is magnesium sulfate also dilates the blood vessels as well. So magnesium sulfate lowers the blood pressure because it's there, but it's not what you think. It's not like it's going to lower your hypertension. It just it lowers the blood pressure temporarily. So I don't want people to think that they can take magnesium sulfate to fix their blood pressure problems.
Okay.
No,
right.
no. So, just keep that in mind. So there's 5 different magnesiums that we talked about. But magnesium is good. It's actually a very good trace mineral that we need to have in our bodies. We need to get it in the foods that we eat. And also vitamins are key. Yes.
Okay, well, thank you. Thank you so much for sharing that. So you mentioned this several times talking about during this postpartum period, our mental state, right? So how often do you come across moms that struggle with depression and anxiety during this postpartum time?
An increasing amount. I think the problem is that we have a lot of information out there and it's not regulated. There's a lot of information out there that's to our disposal, and if we don't gather that information and take it back to the healthcare provider to verify whether or not it's scientifically evidence-based, it can cause anxiety because people Google, and family members Google, and then they tell the patient, oh, no, don't do this because you're going to absolutely die. And I'm like, no, that's really not what happens. So this is what I tell my patients.
So it's a lot of information overload as opposed to there really just being like a shift within the hormones.
It's a combination. So for some patients, it is the fact that there's an overload of information.
Okay.
And taking that information back to the provider to verify whether or not it's true is key.
Okay.
Secondly, you have individuals who do have underlying mental health issues.
Okay.
One of the things that, and this is something about taking care of the whole person. If you've had issue with depression and anxiety prior to pregnancy, it may come back up again postpartum or during the latter half of the pregnancy, the 3rd trimester of pregnancy. Studies have shown that women who've had a prior history of depression or anxiety, anything along that spectrum, it does increase during the 3rd trimester or postpartum because of the fluctuation of hormones.
Okay.
We have the release of oxytocin, all of that has an effect on our dopamine receptors. And so it's key, when I do an intake, I ask any history of depression or anxiety, and it's to help you. A lot of patients are not honest, or a lot of patients just don't know.
Yeah, there's a stigma with it.
Yeah, it's a stigma with it. And, it's all 100% about you. When we're asking questions, it's about you. We're not trying to demonize or stigmatize you. It's all about helping you. And so that does play a factor. So there is a fluctuation of hormones. Should we supplement with hormones?
Yeah.
No.
Okay.
No, you should not. You can do the trace minerals, you can do magnesium, but I'm not a big fan of giving
hormone
hormones.
replacement or testing for hormones and doing that. No.
Yeah, what happens if the patient hasn't recovered soon enough in terms of depression or anxiety, and they're in their postpartum, period? Do you test the hormones to kind of help them out?
No, because
why doesn't anyone test them?
Because it's transient. Remember, the postpartum period is only for a short period of time. So by the time, if you test something it may be back to normal in a couple of weeks. The postpartum period is transit. It's a finite period of time.
Okay.
And then if you give hormone replacement, you can't give estrogen because remember, pregnancy is a hypercoagulable state, right? So it increases the risk of blood clots.
Right.
And then progesterone, it may interfere with either lactation or it can make a mood disorder even worse.
Okay.
So it's such a finite time that if you gave me hormone replacement therapy, by the time it works, which hormone replacement therapy takes up to 6 to 8 weeks to be effective, then we're already
Out of the
the immediate postpartum period.
Ah.
So when there's an issue where there's an issue with mood instability, or mood changes, I should say, then a lot of times there are medications that we use temporarily that are short-lived, quick-acting, that can help during the immediate postpartum period. So that's why, but there's so many things that you can do besides hormone replacement therapy. Like I said, magnesium, trace minerals, there are taking a full vitamin along with magnesium can help with mood stability. Also, finding out what the underlying cause is.
Right.
If it's just hormonal changes, then you give that supportive therapy for that short period of time.
Okay.
And exercise.
Yeah, to help with endorphins, yes. Yeah.
Exercise, have support at home, eat a
Yeah.
good diet.
Absolutely.
And getting plenty of sleep.
I mean, it's definitely, one of those things that, people say it's cliche, but sleeping when the baby sleeps is important.
Yes, that's why.
Instead of trying to do a whole bunch of stuff while they're sleeping.
Exactly. That is why when
So
I'm saying it is hard, it is very hard. I mean, we're all mothers here. Having a supportive family is key, or having a support group. Whether you have a doula, postpartum doula, that help you at home, or an au pair that helps you at home, somebody who is there to help do some of the chores around the house so that you can get rest and quality time with your newborn and get a good breastfeeding regimen is good. And having a supportive group of family members who recognize signs, saying, okay, she's sleeping quite a bit, she looks withdrawn, she's isolating herself, she's having shortness of breath, she looks a little flush. Let's go to the doctor. Let's go to the ED, emergency department. And so that is all key when it comes to that postpartum care. It really is a village.
Right.
One of the things I do want to say is this. At Corey E. Brennan, actually at all of our prenatal clinics, one of the things that we are focusing on is making sure our postpartum mothers transition to primary care. Okay? Because
we can't just keep coming to see you.
no, you just can't. I know. Let me tell you, the postpartum visit rate in this country is under 50%. We bring home the baby, we are taking care of the newborn, we're going to all the pediatric appointments, we're doing the whole breastfeeding, we might even be in a support group. But guess what? Half of our women are not showing up for the postpartum visit. And that is so important because it sets up the stage for subsequent pregnancies. Say, for instance, okay, you have a young woman, diagnosed with severe preeclampsia, let's see, in the 3rd trimester of pregnancy. So 2 or 3 weeks before her due date, all right? That is a red flag for me because severe preeclampsia, like I mentioned before, is related more to inflammation. It's not like chronic hypertension. It's totally different. That puts her at a greater cardiovascular risk long term.
Oh, so you're talking even after the pregnancy.
Exactly.
Long?
Oh, long haul, meaning that whatever is the cause of her severe preeclampsia, which we know is inflammation, whatever the cause of that inflammation, maybe she needs a workup for autoimmune diseases. If she's obese, then we do need to talk about weight loss and the increased risk of diabetes, because inflammation can attack the pancreas, which can affect insulin production, making her insulin resistant. if inflammation can affect cardiovascular, remember I talked about the endothelial cell injury. I know I'm going scientific today. But that is so important. So from a physician perspective, if a woman tells me, oh, I've had severe preeclampsia with my pregnancies, with my last 2 pregnancies, immediately I start thinking cardiovascular risk. Because I'm thinking, okay, she's got either some genetics or there's an underlying medical condition. A lot of patients that come to us don't have primary care physicians. Or they do, they just haven't followed up and have not been receiving care before they got pregnant. So when an OB comes into play, we are kind of primary care.
Right.
Because we're taking care of moms who may not have been seeing a primary care physician. And so we are dealing with stuff that they came in with. Now that they're pregnant, it just kind of adds on. So we have to be that conduit between OB and primary care. And so one of the missions that Corey Brand and all our prenatal clinics in Pompano and Lauderdale Lakes Maternity Center is that we are connecting our postpartum patients with primary care physicians. If they're anemic, they need a workup. Right. Why are they anemic? If they have alpha thalassemia, beta thalassemia, or if they're iron deficient, what's going on? If she has issues with obesity, let's do a workup for, diabetes or even hypertension. Right. And some women who have severe preeclampsia end up developing postpartum cardiomyopathy. So they need to be seen by a cardiologist. Hence, they got to be seen by primary care.
So that's why that appointment postpartum is so important, especially if you have any underlying causes.
Yes.
Right? You can save your own life.
Yes.
Exactly. So, and we have to be around to take care of the children.
Yes. So that is one of the most important things that I want to say is that less than 50% of people show up for their postpartum visits. And like I said, we bring home the newborn, we do all the pediatric equipment, but we don't take care of ourselves. And so showing up for your postpartum visit, because like I said, it sets the stage for future pregnancies. So if we never really dealt with the underlying issue of why you got severe preeclampsia with the last pregnancy, then it's a nice setup for something to happen the next pregnancy. Yes.
So just as we're wrapping up, essentially sometimes when we're looking at preeclampsia or eclampsia setting off this inflammatory response, there's something brewing there, and the pregnancy is bringing it out. Is that what I'm hearing?
So what happens? Yes. So what happens is that during pregnancy, this is the theory. We don't really know the cause. Whoever finds out the cause of preeclampsia will win the Nobel Peace Prize.
Right.
But it's the mother begins to release pro-inflammatory proteins. She may already have inflammation from either diabetes or pre-diabetes, or she's got labile blood pressures, or she's got metabolic syndrome, which means that she's got, borderline high blood pressure, borderline diabetic, and also obesity. Okay. So there could be also underlying autoimmune things that are causing inflammation as well. And so now she is pregnant, that puts more stress. The stress is also inflammatory, puts more stress on the body. And so now everything eventually comes out during pregnancy in some cases.
Got it.
Yeah, that is why, I love obstetrics, because it's dealing with the whole person, physically, mentally, and emotionally. And so, I just want women to feel empowered, to know that they've got to take care of themselves. And you have to put your mask on first, right? Yeah. Before you can put your mask on anybody else. And so that's one of my biggest messages, is that moms come back to us after you have the baby, because there's so much we have to talk about, birth spacing, contraception. You may not be interested in contraception, but let's talk about some things that we may have encountered during your OB and prenatal visits that need to be addressed.
Yeah. That makes sense. Yes. All right. So, and you're the right woman for the job. And we appreciate you.
Thank you.
Man, this was such a powerful conversation. Yes. And I learned so much just here listening to you. I loved it. Right. It was beautiful.
I did go a little bit scientific. Yeah. I'm sorry.
It's okay. It's okay. Yeah, no, we need to. I mean, you're a professor at this. It's beautiful. So, biggest things, guys. All right, go back to your postpartum appointment. That's important. Know the signs, the symptoms, recognize it. And then for all my families out there, support each other. Recognize that pregnancy, childbirth, it's just not a one person show. We need the whole village out there being able to take care of each other, being able to recognize how we can continue to uplift and support our pregnant mamas and our recently delivered mamas out there. Alrighty?
Yes.
Okay, so thank you again, Dr. B.
Thank you.
Appreciate
It's been a pleasure.
Yes. All right, I'll see you next episode. Bye.
All right, bye-bye.